Good morning, everyone, and welcome to this week's Department of Medicine Grand Rounds. Before we get started, just a few housekeeping tips. Please keep your video and your mics muted. Also, we ask you to hold your questions and comments till the end, at which time you can unmute yourself or put questions in the chat box. Lastly, the CME information for today will be periodically placed in our chat box. And thank you so much for joining us today. Today, our speaker is Dr. Roxana Mehran, joining us from Mount Sinai in New York for a presentation on contrast-associated acute kidney injury. Dr. Mehran currently holds many positions of leadership in her field, and among them is Professor of Cardiovascular Clinical Research and Outcomes and the Director for the Center for Interventional Cardiovascular Research and Clinical Trials at Icahn School of Medicine at Mount Sinai. She received her MD from St. George's School of Medicine in Grenada and completed her residency and a chief year at the University of Connecticut, and finally completed fellowship training in cardiology, then interventional cardiology at Mount Sinai Medical Center. Dr. Mehran specializes in multi-center, multinational clinical trials with complex data analyses and outcomes research. Her extensive research interests include mechanisms of neointima formation and restenosis, treatment and prevention of acute kidney injury in cardiac patients, gender and women-centered studies, and advancing pharmacologic and interventional treatments for acute coronary syndromes and myocardial infarction. She has over 20 years of experience working with regulatory agencies to design and conduct clinical trials and help shape health policy and clinical standards and guidelines. She has served as a principal investigator for more than a dozen national and international multi-center randomized trials and is currently one of several lead investigators to collaborate with the FDA to develop standard definitions for clinical trials in cardiovascular disease. We welcome you and thank you, Dr. Mehran, for joining us today to give this presentation on contrast-associated acute kidney injury.
Thank you so much for having me. It's really a wonderful pleasure to be with all of you. Probably should have been there in person. It would have been nice, but it looks like you guys are still on Zoom. We've started a little bit of kind of having an in-person. I just came back from the TCT meeting, our first national meeting with international, national, global meeting over in Orlando. We had 2,500 people in person, and it was really, really great to just have everyone in person. So let's keep vaccinating everyone so that we could get over this and get back to our normal lives. It's really a wonderful, wonderful honor to be with you. The CME credits are important. This is a CME lecture. I'm sure that they'll give you all the details about what you need to do, but make sure that you text the code. This is the text code number that you have to text this code to this number listed here. And I'll put it again at the end of the slides if you didn't catch it. These are my important disclosures for the work that I do in the academic research organization that I lead. We have over 100 trials that we lead here at the Icahn School of Medicine at Mount Sinai, and therefore there's a lot of research funding to our institution. As it pertains to this talk, I really have nothing to disclose at the moment. So contrast nephropathy. So let's get the terms right. And I think this is going to be a little bit of an education. So we've always talked about contrast-induced nephropathy and how it was defined in the past, and it's always been that way for all of the older literature. When we first started focusing on this, when I first started focusing on this, it was really under-recognized, underappreciated. And we started seeing that in our patients post-PCI, they would have acute kidney injury. They would have what we called contrast-induced nephropathy after they received contrast. And it was defined as 0.5 milligrams per deciliter of serum creatinine increase, or a 25% relative increase from the baseline serum creatinine, which would occur somewhere between 2 to 5 years after exposure to contrast agents, usually returning to baseline within about a week to 10 days. And still, we found that there was an important association. So I'm giving you a little bit of a history, and what we now are realizing that there are other factors. This isn't just about contrast media causing acute kidney injury. During our procedures, there are medications, there's atherosclerotic materials, we're putting catheters up and down the vessels, there's hypotension, there's hemodynamic changes that all precipitate acute kidney injury, as our nephrologists would recognize. And so we now basically have changed this to contrast associated acute kidney injury, or really it's not nephropathy anymore, acute kidney injury. And the historical perspective is there for it. There's evidence in animal models with toxicity with contrast agents. There's evidence that includes the functional decline and important histological changes. And these the animals that were made vulnerable by combining dehydration, prostaglandin inhibition, nitric oxide inhibition, and reduction of the nephron numbers have been shown with exposure to contrast media. And the human models also have been very, very telling. High osmolarity contrast media are associated with acute kidney injury. We don't use them anymore. And of course, low and isoosmolar contrast media are obviously much more friendly to the nephrons. And there's also some evidence that have shown that you can make patients less vulnerable by giving them volume, avoiding diuretics or dehydrating patients beforehand, avoiding non-steroidal anti-inflammatory drugs, also avoiding nephrotoxic agents. And there's never really been an important contrast-associated AKI biomarker, although now there are lots like cystatin C and NGAL that's being developed, but none of them have shown really important. But there are some issues that we could pick up perhaps acute kidney injury even earlier. But let it not be forgotten that there's also been a lot of controversies. Nephrologists, even radiologists say, well, changes in creatinine is very frequent in hospitalized patients, especially whether they do or don't get contrast media, and it could occur with equal frequencies to reported incidences of acute kidney injury that we have seen. And of course, the other is that some of the retrospective observational data show a similar incidence of AKI in patients who get a CT with or without a contrast media. But all of these things have a lot of, I believe, limitations in these kinds of controversies. First of all, the trajectory of creatinine change has never been assessed in those studies that have been shown. And in fact, there are the patients that they looked at with the hospitalized versus with CT scans, with or without contrast media, there are really different cohorts of patients, different comorbidities. There's important selective bias, and they had very few patients with low eGFR. Let me bring you now to the current definitions. This is pretty important. It's important to kind of think about how are we going to be assessing acute kidney injury. The nephrologists and the this is in Kidney International, very important that to understand that now it's even a stricter criteria. It used to be 0.5 milligrams, even a 0.3 milligrams per deciliter increase is associated with poor outcomes. So acute kidney injury from the Acute Kidney Injury Network, change from baseline, increase in serum creatinine of 0.3 milligrams per deciliter within 48 hours, or an increase in 1.5 to 2 times above the baseline, or any urine output less than 0.5 milligrams per kilo per hour over a 6-hour period is considered to be acute kidney injury. And I think if you look across the way, they've become more strict, and therefore this is really important. And you can stage it depending on how the severity of the acute kidney injury as well by these important new definitions. The misleading use of creatinine for making this diagnosis should not be underestimated. And we believe very wholeheartedly that it's important to look at the GFR as it looks at the kinetics of the creatinine distribution amongst the body's fluid compartments. serum creatinine is insensitive in patients with normal kidney function and in the case of rapid changes. So very important that all of you, when you are diagnosing chronic kidney disease, that you're actually looking at this on an estimated glomerular filtration rate. We were using the MDRD formula or the Krakow-Gault. The MDRD formula, as you know, has a race equation in it. And since all of the evaluation, we believe that the use of race underestimates and actually makes a negative impact on our African-American patients, and race has now been taken out of that equation. It's under play. So for now, the Krakow-Gault formula is what we've been using, although we double check all of our data when we're developing risk scores, et cetera, with the MDRD taking out the race equation out of there. So now that you got I hope you all got the definition straight, let's talk about the epidemiology and the relevance. Why do we care about this? If it goes back to normal, well, who cares? There was a little bit of a change. There was some hypotension. Maybe it was dilutional, or maybe it was dehydration or whatever. This is the most frequent complication of interventional procedures requiring contrast media. It's the third leading cause of acute kidney injury. Although it's self-limiting, there is a very, very important association with mortality. So here's what we need to kind of think about, the morbidity and mortality. First of all, you can, and we've looked at this with the different stages most often, and thank goodness, about 7% of the procedures are having some acute kidney injury, as you could see here. Most of these is the first stage, but these are also there, about 1% overall. You're going to have AKIN 2, 3, or dialysis. These are really high levels. Take a look at what happens with association to death, bleeding, and myocardial infarction when you have no acute kidney injury versus when you do, and especially when you end up on dialysis or renal replacement therapy. We have shown this over and over again, and in the interest of not showing my data, which was old, I'm showing you the newest data. This isn't going away. A very, very important association, especially if you end up with AKI stage 2, 3, where you end up with much, much higher rates of death, MI, bleeding over a 1-year period after. So even if they go back to normal baseline, these patients are at risk. So then you'll say, well, maybe it's because of their risk. Well, when you put this in a multivariable model, AKI comes out as a predictor, as an independent predictor. It's also very expensive. For those of you who care about the healthcare dollars, the length of stay, what you get dinged on, what the hospital makes, etc. When there is AKI, this is the data from the French hospitals, but we have it from US hospitals. There is increased there's increased length of stay, increased ICU stay, especially there is renal replacement therapy. Now, if there is renal replacement therapy, even if it's very low, these are the light blue, you see what is happening to the cost of the patient that stays in the hospital. But when you develop AKI and you keep that patient overnight to see that their creatinine is going back down, take a look at what's happening. It's 2-3 times the cost of the patient who doesn't have AKI. The mechanisms are complex. There is a direct nephrotoxicity to the renal tubular cells, especially in the proximal tubules. These are loss of the tubular epithelial cells due to the redistribution of the sodium-potassium ATPase from the basolateral to the luminal surface of the tubular cells. There is very abnormal ion transport that increases the sodium delivery to the distal tubules and leads to what we know is happening is renal vasoconstriction. And this has this tubular glomerular feedback and a progression of cellular injury where the epithelial cells detach from the basement membrane, result in luminal obstruction, increase intratubular pressure, and the glomerular filtration rate is as a result reduced. So this is a real thing and it happens. This is the figure I put together for the New England Journal of Medicine review that I was invited to put together. And I tried to explain this in a way that not only is there a direct tubular toxicity, there's also indirect issues with arterial vasoconstriction, a very important blood increase in viscosity and osmolality when you give contrast agents, when they go through that first pass into the kidney, when you inject it into on the left side, obviously, where there is microvascular thrombosis, prolonged ischemia in the outer medulla, and impairment of the renal function. And the direct tubular toxicity I already basically explained. So the ischemic injury, as well as the increased blood viscosity, is something to think about. Every time you keep pushing, oh, let me see what it looks like. Let me see what it looks like in the cath lab. For those of you who are in the cath lab, beware that you are exposing the kidney to toxins and to damage. Because, why I say this, because unfortunately, there is no definitive treatment of contrast-induced acute kidney injury. The only thing we can do is to prevent it. And the preventive strategies are the most important measures. And we believe, and this is from, I basically put a very, very simple guideline for everyone. It's pretty simple, but people don't follow this, believe it or not. You need to determine the risk of the patient. You need to assess those risk factors using some of the prediction tools that we've made available. The high-risk patient really needs a lot of attention. We'll talk about who those patients are. We have to, when there is a high-risk patient, you have to absolutely minimize contrast volume. You have to always, on every patient, think about the low or isoosmolar contrast media, suspend all of the nephrotoxic agents. And in those high-risk patients, hydration is key, absolutely key. And we do a very poor job in hydrating our patients. So these are the three pillars of prevention. Identify the high-risk patients, hydrate before the procedure, minimize contrast volumes. That's so hard to do. It's really simple 3 steps. And you could take down the risk of acute kidney injury, even in that highest risk patient, from 12% down to 5% if you just did this. And it's absolutely worthwhile. So how do you identify that high-risk patient? I also made that simple for you. There are several risk scores. I developed the first one. It's in a tool that everybody is using. But honestly, if you want to be lazy and don't want to go on an app to use my risk score or anybody else's risk score, think about these 4 things. CKD, measuring the estimated glomerular filtration rate. Anyone with hemodynamic instability, your STEMI patient, your cardiogenic shock patient, the patient who has congestive heart failure. The combination of diabetes and CKD together, which is a killer. That's why I always ask for diabetes. And what's going on with the serum glucose of the patient? And as I just said, congestive heart failure. Think about those 4 things. That's not that hard either. I'm trying to make it simple because I know everyone has, especially our younger generation, just want answers right away. Here it is, right here for you. Some of the pitfalls of the risk models, even the ones that I've developed, you still have to examine the patient. You know, they'll say, oh, there's no congestive heart failure. You'll go to the bedside, you see this neck veins. This patient has right-sided heart failure, and maybe they just didn't document it. You still have to examine the patient. You still have to look at that patient. You have to assess their fluid status live, not just by seeing what the history is. And I think that very, very important issue is that when you have a patient like that, and I'm telling you, you have to hydrate them, how are you supposed to do that? So you tailor it in those patients, especially those with congestive heart failure, severe CKD, where you're very concerned about hydrating them. And I think it's very important to assess those important patient-related risks. This is my risk score published in JAC 2004. We have a new risk score with a recalibration because you could see these rates are so huge. Look at what you get, about 57% if you scored over 16 points in this score. And we've done so well, thank goodness for all of the work that everyone has done in reducing the incidence of acute kidney injury, that we needed to recalibrate the score and think about new model. And a new model has been accepted to the American Heart Association late-breaking clinical science, which we will be presenting, and it will be published simultaneously in a very high-end journal. Hopefully you will all tune in. It will be in AHA. Unfortunately, I can't show it to you, but here's what we have. I put these 4 pillars. Use of diuretics and non-steroidals is there because you got to think about, these are usually, you have to go to the bedside to see if the patient and talk to them, because no one puts in if a patient is taking non-steroidal anti-inflammatory drugs like Advil every other day or something like that. So the risk assessment is a 2A. So you've got to do it. It's in the guidelines as a 2A, and very important to kind of take that into account. So let's go over some of these important issues. The underlying CKD is the most important, powerful predictor of contrast-induced acute kidney injury after cath or PCI. As the estimated GFR declines, there's less functioning glomerular. So when you have high concentrations, you're exposing that patient to that much more. And then, of course, from the NCDR, we have a very, very big linear relationship of the incidence of acute kidney injury with estimated GFR. Diabetes is a very, very important risk factor as well. It could go up to 50%, especially if there's CKD. Most of these patients have some CKD. And of course, uncontrolled glycemia is another one that causes and brings, and imagine that the patients who are diabetic under trauma with a STEMI who have hyperglycemia, they will have a higher incidence. And remember that a STEMI patient, you hardly have any of these data in front of you because you're jumping in the lab and opening the blocked artery. So there is a direct association that has been well documented now of the plasma glucose level to contrast-associated acute kidney injury. And as you notice, it wasn't in my previous risk score because we didn't have plasma glucose in the model, but we will in our new model, and we'll see if it's a risk. AHA 2021, this weekend. The impact of congestive heart failure is huge. I mean, you can imagine what's happening in a patient who's in congestive heart failure. There's hemodynamic instability, there's renal congestion, there's low cardiac output. These are all major determinants in just reducing the estimated GFR. And of course, there could be a very, very important synergistic effect of using diuretics with contrast media in determining the intrarenal vasoconstriction and ischemic injury. So it becomes a circular argument. Here you have a congested patient, renal congestion, you give diuretics, you cause more vasoconstriction and more injury. So it's a very, very fine balance. These are the patients that will require a very ginger and evaluation. I'll tell you what we suggest here. The hemodynamic instability is a no-brainer, right? There is a direct correlation of renal blood flow and shock, obviously. So STEMI cardiogenic shock patients Also, we've seen a strong association of intra-aortic balloon pump, not only in the fact that you're putting it right up the aorta and each time the balloon is going up and down, there could be atheroembolic debris that goes in, but also obviously hemodynamic instability and the use of a balloon pump, that association is difficult to tease out as causal versus reactive to the hemodynamic compromise. So high-risk patients, very, very important, and I put those 4 pillars out there for you: CKD, diabetes, hemodynamic instability, as well as congestive heart failure. And now I'm telling you hydration, how important it is. It is really important because hydration increases glomerular filtration rate, has a dilutional effect for contrast concentration in the filtrate that goes to the kidney. And of course, if you imagine that in the medulla, when you have a dilutional effect of that contrast media, you'll have decreased oxygen consumption, a lower need for sodium reabsorption, less oxidative stress, less contact time with contrast media with tubular epithelial, and of course, reducing the vasoconstrictors, all the things I talked about. Is it preventive? Well, take a look. The people who received no hydration, those who received before and after, really important that hydration is important before, during, and after the procedure. It's not just, I just do it before the procedure, I'm done. You got to do it before and after. And I think that's a really, really important element to think about. We can no longer do a study like this because it's unethical not to hydrate patients. So it's really important. So what's the timing of that hydration? Is it just a rapid hydration immediately before and after? A lot of people try to do that to save time. Well, I can tell you that it's not. It's not about quantity of fast hydration, but rather the quality of ginger hydration beforehand. So there's this hemodynamic stability, and that there's, well, that you give time, especially in those high-risk patients, for about 12 hours. So don't put your CTO with multitudes of multi-vessel disease where you have a complex thing on the first case and have the patient come in with just oral hydration and no time for IV hydration. Also, don't have the patient be the last case MPO and get completely dehydrated because you just forgot they've been waiting and waiting and waiting and not getting hydrated. So you've got to pay attention to this. If you have later dates and they're coming in at 6 in the morning, they should get hydrated regardless of their risk, because you will just reduce the incidence of acute kidney injury. There have been really, really good studies on hemodynamic guidance for fluid administration. I love this study, the Poseidon study by my good friend, Sam Brar, who was trained with us and is now in Kaiser as a major leader. He did this study because he wanted to once and for all figure this out. Using LV end diastolic pressure guided hydration with 0.9 normal saline versus the usual standard hydration. What they did is as soon as the patient came in the lab, they basically put in evaluated the left ventricular end diastolic pressure by just putting in a pigtail into the LV and hydrated the patients at 1.5 to 3 to 5 milligrams per kilo per hour, depending on what that left ventricular end diastolic pressure was. And you see that. If it was over 18, they still hydrated the patient, 1.5 mils per kilo per hour. And what did they show? That when they used the LVEDP guidance, they were able to reduce acute kidney injury by a major order. And it was just a very, very important study. So here's a tool that you could use to guide your hydration. If you just don't know, you can get the numbers when the patient is in the lab, but you should have hydrated that patient beforehand. And then you can guide yourself during and after the procedure by measuring the left ventricular end diastolic pressure. What about this concept of high urine output? There is studies that have been done with this system, and I was part of some of these studies where the patient is given a Foley catheter, and basically the urine is being weighed, and the exact amount of the urine output is being matched by fluid going in and chased up with diuretics. So a very high urine flow of 250 or 150 to 200 cc's per minute, like really pushing the fluid through the kidneys, has been shown in some studies to reduce acute kidney injury. But in this US study that we ran, did not show to be beneficial. So this is not really a way to go, but it's something to think about. The urine flow, the Prince study showed that high urine output, when you see patients putting it out by giving them IV fluids, is a good thing. And it's good to see that and watch the urine flow. And you can see that here in Remedial 3, when investigators randomized the urine flow rate versus the LV end diastolic pressure guided hydration, that they actually had a better result by getting a very high urine outflow. So I would say kind of measuring all of these things are important in your hydration. Isn't it something that we actually have to know how to hydrate patients, because people are missing and not understanding how best to hydrate patients? So as I talk about this, let me bring up a very controversial study. Here's a study of patients with estimated GFR of 30 to 59 cc's per minute, so CKD patients, with a prophylactic hydration to protect renal function from intravascular iodinated contrast media for contrast-induced acute kidney injury. This is the AMAZING study, prospective randomized study of only about 650 patients. And look at what happened. Absolutely no change whatsoever in contrast-associated kidney injury, even when they used prophylactic hydration of 0.9 normal saline. The standard prophylactic hydration was 0.9 saline, 3 to 4 mils per kilo per hour, 4 hours, and then 4 hours after. This was 12 hours versus 12 hours. What I'm seeing here, that both groups got hydrated actually, and the hydration was a good thing because both groups had a low contrast-induced acute kidney injury. That's what I see. But the other thing that I see that is a huge limitations of this study, that's that was only 16% interventional procedures, where we know those are higher risk patients, where longer hydration is going to be very important. This wasn't about no hydration versus hydration. This was a 12 hours versus a 4-hour hydration study. These are both hydration arms. The event rates are low, which tells you that it's very good to hydrate patients. This was only in a single study, single center, and they didn't get creatinines on everyone. So we might have missed some of the patients who would have been at high risk. And these weren't really high risk patients with high risk procedures. But then there was this other hydration regimen of sodium bicarbonate that had come. Oh, this is a great way to go ahead. And N-acetylcysteine, also another study that showed, yes, it could be effective. I can tell you that both of those, sodium bicarbonate and N-acetylcysteine, both were shown in large prospective trials not to be effective. So I don't know why this group, Preserve trial investigators, I give them a lot of credit, 5,000 patients, 2x2 factorial design of bicarbonate and acetylcysteine versus placebo. They use double-blind placebo controlled. So this is very good. Sodium chloride versus sodium bicarbonate. And what they showed, absolutely no benefit, as we would have imagined, that the primary endpoint, sodium chloride versus sodium bicarbonate. Bicarbonate is not the way to go. You don't have to make patients alkalemic just because you want to preserve acute kidney injury. Sodium, normal saline is just the way to go. And of course, N-acetylcysteine did not make a difference at all whatsoever. Now let's get to the last. So minimizing contrast media. No question, this is really important. I believe that the osmolality is incredibly important. And a lot of you don't know that when you go even from high osmolar to low osmolar and then to isoosmolar, even though the osmolality reduces with isoosmolar, viscosity increases. So very important to understand your contrast media. It's something you're given to the patients. And the volume being minimized is a 2A indication because of the fact that anything above 350 cc's or more than 4 mils per kilo or repeated administrations after initial administration is associated with acute kidney injury. That is like causal, frankly. So when you get to 200 cc's, you better watch and you better stop and take a breath and say, what am I doing? The enemy of better of trying to make it better is really a negative thing for these patients. And I think very important to think about that when you're on the left side with arteriography, you get more concentrated contrast media reaching the kidneys, increasing the risk of contrast-induced acute kidney injury. Volume matters. I already talked to you about this. There is a direct relationship to the concentration of contrast media in the glomerular filtrate in renal tubular. So when you have more, you are going to end up with a much higher rates of acute kidney injury, vasoconstriction, oxidative stress, direct tubular injury. And of course, we already talked about dehydration and how that reduces the glomerular filtration rate. I want you to pay attention. I put this slide also from the New England Journal Review article because I believe most of you don't know anything about osmolality of the contrast media that you're actually prescribing and using in your procedures. And it's important to note that. It's important to know that high osmolar compounds are out. High PEG is no longer being used. But look at the low osmolar. There's nothing low osmolar about low osmolality compounds that we're currently using. It's still quite high in the iodine concentration. The osmolality is not 1,500 osms per kilo. It's about 600 or 400 to 800 osmoles. The viscosity is somewhere between 2 to 9. And then if you actually go to the isoosmolar compounds, they're actually very low osmolality, the same osmolality as your blood, but look at the viscosity, which is that much higher. Viscosity matters as well. So remember that the risk of contrast-induced acute kidney injury depends on the iodine content, osmolality, the degree of polymerization, ionicity, as well as viscosity. And at the moment, we don't have the perfect contrast media that protects patients. They're both toxic. And there is no difference between these two. So when you're, okay, with a low osmolar, you're gonna have less like side effects, especially when you inject the lima or something. But there's never been a study that has shown that there's less AKI with the different isoosmolar versus low osmolar, because what you get back from the isoosmolar compounds, you pay back with viscosity and other issues like ionicity and iodine content not being any different. So use of isoosmolar or low osmolar is class 1, and isoosmolar over the low osmolar is a 2A based on the side effects for the patients, not AKI. Why do we measure this? Because the volume is one of the few modifiable things that we could do, right? The volume of contrast media. We're in control of that. And of course, you can't modify what you don't measure. So please measure how much you're giving. And there are really important data now that shows this very important relationship between contrast media and the ratio of contrast media to creatinine, of what you're doing to the volume and how you're exposing patients to more contrast-induced acute kidney injury. So how do you reduce contrast volume? Well, you could use this GFR-based dosing, confirm the thresholds up front, and get timeout from your team. Monitor that at all of the cases that you are doing. In those high-risk patients, I always do biplane, try to avoid LV-gram aortography when the GFR is low, get an echo beforehand. Pay attention to these things, especially in that diabetic patients. When we are doing PCI, we will use like IVUS or buddy wire, use the balloon. Don't keep injecting because you think you're going to see better. I mean, dry cynates help you. And I think we have to be very, very careful about contrast volume. And you know something, when you refer patients to the cath lab, always look at the cath report and see how much volume your patient got. And if your patient got more than 200 cc's, call that interventionalist back and say, why did you give that much contrast? And I think we have to keep each other accountable for these things because they need to be paying attention to this. Staging procedures are important as well. Don't do everything all in one slew, and then don't stage the procedure on 4 days after, but wait a month, let that kidney recover before you expose it again. And then of course, mechanical circulatory support in high-risk patients where you could take it easy and not keep giving contrast and be calm in your procedure sometimes could be helpful. This is my final flow diagram here for you to think about contrast media. First of all, whether it's an elective or urgent procedure, always even in the urgent procedure, start the hydration immediately with isotonic, and then evaluate the LV and diastolic pressure immediately. You bring in the patient to the lab, start the IV fluid, and give the hydration as we talked about from the Poseidon trial. Always, always minimize. You see the green bars is minimizing the volume, always for everybody, no matter what the risk is. And of course, I already talked about what kinds, and then continuing the hydration in these high-risk patients is very, very important throughout. And then in elective procedures, risk assessment, you have time, assess the risk. If you have high-risk patients, you need to do hydration. Intermediate risk patients still everyone is getting hydration, but with in the elective patients, you have time. Do that ginger hydration 12 hours before. I want to talk about a couple of other preventive measures. Here's a really interesting preventive strategies that are looking at, this is a network meta-analysis looking at pretty much everything: statin, N-acetylcysteine, sodium bicarbonate, ascorbic. Look at all these things that have been previously measured: preconditioning, natriuretic peptide, and you can see that none of them really are working, except statins. And isn't that interesting? The statin administration before could have some effects. We don't know why. There's a lot of pleiotropic effects of statins. And even these other ones, they're not consistent. This N-acetylcysteine, sodium bicarbonate, N-acetylcysteine plus sodium bicarbonate. There were so many trials there, but these data are inconsistent. And I think the last one from the New England Journal really puts the nail in the coffin of these things. Let me talk to you a little bit about statins. This is the Prato ACS study where they did randomize patients, consecutive statin naive, non-ST elevation ACS patients undergoing early invasive strategy to high dose statin, 250 patients versus no statin. And their crude odds ratios are here, where you see a major reduction in acute kidney injury in 48 hours. There have been 9 clinical trials that have been done with over 5,000 patients, and the results look really interesting, that there might be a benefit of statins. And at the moment, the European Society of Cardiology 2018 guidelines, it's really talking a little bit about hydration with the matched hydration and diuretics, but does not really mention statins. One last interesting part is, what if I remove the contrast media by placing a catheter into the coronary sinus? And so I would basically not let the contrast media get in to the renal bed. This was a very, very interesting randomized trial. Diabetics patients with renal impairment undergoing angiography. The coronary sinus catheter was able to take out about 40 cc's or so of the contrast media given. And the renal, the issue is that it really didn't show any kind of a benefit. So it may be important to get a third of the contrast media out, but you still are giving a lot. And what happens when you do these cases with these coronary sinus catheter and go, oh, well, you know, I removed a lot of this, and so therefore I'm going to be good, and you just keep giving more dye because you think 30 cc's come out. And we did a study with a very interesting injector that was basically not allowing you, as soon as the coronary was filled, the pressure would stop you for pushing extra. So we basically saved the same way without putting anything into the coronary sinus. We saved the giving contrast media, but that wasn't associated with reducing acute kidney injury. You need to just do a lot more and be very, very cognizant. So finally, in conclusion, I think I've given you a lot about the mechanism. Acute kidney injury after contrast media is real, okay? It's not always just contrast, it's also medications, hypotension, atherosclerotic issues. So it's contrast associated acute kidney injuries. The patients who are at high risk are those patients coming to the interventional suites, receiving PCI, high risk PCI, and we're seeing older, more risk studied patients. And so therefore we have to be very careful about risk assessment. And the only way we can prevent this important complication at this point is risk stratification using low or isoosmolar contrast media, with minimizing the volume and hydrating these patients before, during, and after the procedure to minimize the incidence of this important complication. I can tell you that there are several pharmaceutical companies developing interesting compounds where I'm going to be involved in a very large prospective study in CABG patients to see if we could reduce, and this isn't always associated with contrast. In CABG patients, we see a very high rate of acute kidney injury. So the future is bright. We are looking, and companies are looking at different modalities to try to come up with preventive measures. Important again, for your CME credits, please text the code 11729 to 888-816-4893. Thank you so much for having me. I think I've left you some time for questions if there are any. Thanks again.
Oh, Dr. Mehran, thanks so much for a really wonderful talk. And and for all that you've done in the field in interventional cardiology. For those that don't know, Dr. Mehran is a national and really international leader in interventional cardiology in many, many areas. And again, we thank you for all of your education and leadership in interventional cardiology. So we do have some time for some questions. That's great. Thank you. I'll start off perhaps, and in a high filling pressure, low cardiac output patient, so their LVDPs are already elevated, cardiac outputs are very low. They also have high right-sided pressures. Any benefit, for some inotropes, perhaps some vasodilatation on the right side to increase glomerular filtration pressures? Anything come out on that?
Yeah, so those have been, I didn't go through all the historical data because they're really old, but low dose dopamine is really not effective. It just hasn't been shown to be effective, and in fact, it could be detrimental for the patients. There could be some vasodilatory effects in the kidney, but then the patient's own cardiac function can deteriorate and then have worsening, could be worse. So there's absolutely no benefit on low dose dopamine, which used to be what we used to do, if you remember. And there is no benefit there on vasopressors whatsoever.
So no use for inotropes or any kind of other vasodilators, right?
Not
Thanks
for
so much.
kidney injury and in these high-risk patients. There haven't been really large-scale trials. So for now, we don't have any kind of a recommendation there on that.
That's great. Thanks so much. Other questions, either chat or if you want to raise your hand, I see.
There are two raised hands here.
Yeah, great. Dr. Greenstein, is that you?
Yes, that's me.
Go ahead, please. Thank you.
Thank you so much for a very interesting talk. I wanted to get your perspective. In the critical care literature and field, a lot of the thinkers have really started to move away from the concept of contrast induced or associated nephropathy. And one of the issues being a lot of the literature, you can't do a randomized controlled trial. And of the propensity matched trials that I'm aware of, they really don't bear fruit in showing that there is a true association. So I'm wondering, obviously the cath lab is different in terms of the amount of contrast being given, but do you view things differently with radiology procedures?
I absolutely view, and I was on those, I listened to some of those ASN. Is this from the ASN? I know there was a huge session in the ASN meetings last week, as well as I heard grand rounds now by some nephrologists saying, "Oh, there's nothing like this." I can tell you that this is a real issue, and I think it's a very negative thing to say that there is no association, that contrast media are inert, and that it's fine, that there is no such a thing as contrast-associated acute kidney injury. That all of the arguments I brought forth, I don't know if you were a part of the first couple of slides, I tried to explain that there is exactly what you're saying out there, but in our world of large volumes of contrast media and more of use of invasive procedures, both in interventional radiology, as well as now PCI, TAVR, mitral, tricuspid. These are high-risk patients, and contrast media absolutely have an effect on the kidney. And I showed all of the animal studies. I mean, it makes a great deal of sense. We've done a lot to reduce this and bring it down to single digits. It used to be 20% of our procedures. And in the recalibration of my risk score, which will be published very, very soon, you will see those numbers are very, very different. There are important pre-procedural risks that expose these patients to the risk of acute kidney injury after PCI. I can only speak to you after PCI. Because that's where you see the effect of contrast media. And to now say, well, there is no such a thing as contrast-associated acute kidney injury, I believe is a misnomer and a very bad thing to do in medicine, because we see it all the time.
Thank you. Thanks very much. Dr. Schwartz, do you have your hand up? Okay, while we're waiting, anybody else also, please put any questions you have in the chat. Let me just ask Dr. Mehran, what about these diastolic dysfunction patients, who have a totally different pressure volume relationship, and do you follow that same, would you follow that same kind of volume recommendations for those who really truly have diastolic dysfunction?
I mean, this is such a good question, and I wish that I had the answer to that. I can just tell you in the Poseidon study, they didn't distinguish between low EF or high EF or preserved or no heart failure patients. It was an all-comer patient population. And I don't think that they had enough data to actually divide that, but you make a very, very good point that not all heart failure is the same, and that the pressure volume relationships are very different in those patients with preserved ejection fraction versus those with reduced, and they both could have congestion, pulmonary congestion, etc. So it's a very, very good point, but I just don't have the answer to that. There's no data in the literature. It's a great way to do some research though on there.
Yeah, well, thank you. So if you don't have it, then we can feel that we can look at something like that. Thanks very much. Other comments or questions for Dr. Mehran?
Yeah, I have a question.
Oh, Dr. Garden, yeah, please go ahead.
Yeah, so certainly a wonderful talk. Of course, in the old days, digital subtraction angiography helped improve contrast and was, a mainstay of efforts to, in effect, reduce the need for contrast. Are you aware of anything on the imaging side in terms of that improvement in digital subtraction or other techniques that will allow us to reduce on the front end the amount of contrast delivered?
Thank you, Dr. Gardine, for your excellent question. And it's absolutely true. We're now performing procedures with zero contrast by use of intravascular ultrasound. There's been a beautiful case series using intravascular imaging to guide our intervention without a single cc of dye, which is incredible, but it's absolutely what we're all doing. Some of us, and in our institution, we've done this. In other institutions, there are, using imaging, intravascular imaging will reduce substantial amount of dye. And we store fluoro, and now a lot of the fluoroscopy suites, all the new cath labs are really, really registering how much contrast you're giving. They're using the important cine, dry cine, storing fluoro, all of those things so that you never have to continue to keep giving dye. And just with that, you could reduce the contrast volume by like 50%, honestly. And
Wow.
So I think there are a lot of ways that everyone is kind of thinking about how we could reduce. I think if we, the first question is a good one. And I think the nephrologists now and the radiologists who are doing all these CTAs and don't want to be upset about, oh, am I going to cause, they want to make this go away, are enjoying the benefit of us actually recognizing that there is contrast-associated acute kidney injury, that preventive measures do work. And now it's so low that they're saying, oh, there is no contrast-associated acute kidney injury. And we should not be fooled by that, because there is contrast-associated acute kidney injury. It just depends on what you're doing and what you're not doing. You can prevent it by doing all the measures that I gave you, and then you could say, oh, we don't have it, right? Just like they're enjoying the benefit because we've put it out there to hopefully prevent by hydrating patients beforehand and minimizing contrast volume.
Thank you.
Dr. Mehran, I want to thank you again for a wonderful talk. Unfortunately, our time is up this morning. Thank you so much for visiting with us, and we really appreciate it. And thank everybody who joined this morning. I'm sure everybody learned as much as we did. So again, thanks so much, and wish everybody a great day.
Thank
Bye-bye.
you.
Thank you.
I hope to visit you in person someday. Thank
We'd
you all.
love that. We'd love that, Dr. Moran. Thanks. Great to
Thank
see
you.
you.
Bye-bye.